in Fargo a couple months ago, I wanted to just go over what to expect at your new patient visit. So it's less intimidating to make that first initial visit. I know it's just never a situation that you anticipate being in, but I want to make it as user-friendly and as seamless as an experience as possible for you guys. So that being said, my goals of things to kind of go over today is the timeline for that new patient visit, what it's going to look like for you. So usually I go through kind of introductions and then a little bit of education for my patients, because I feel very strongly that your ability to understand what's going on helps you to make the best decision for you and your family moving forward. And then talk about some evaluation options and then options for treatment moving forward. So with introductions, what I'm talking about is trying to find out more about you. So what are your primary concerns and what are your family building goals? Are you 35 and want to have 5 kids? Or are you 28 and want to have 1? You know, because all those things will play into ultimately the best treatment cycle for you. And then finding out more about you. What's your medical history? What's your surgical history? What's your pregnancy history? How long have you been trying to get pregnant? What's your periods like? Do you have them every month? How long are they? How heavy are they? And do you have any pain with your periods? How often are you having intercourse? Or are there any problems with that? And then are there any other signs or symptoms of other underlying problems like endometriosis or elevated prolactin levels? Do you have PCOS or symptoms of PCOS? And so I like to talk to you just to find out this information. And then find out about your partner. How old are they? What do they do for work? Have they had children before? Do they have any other factors that might be affecting their ability to conceive, such as a history of any STDs, surgery or trauma, any medications that they're taking, and then any work exposures or previous exposures to things that can affect their fertility. And then has your partner had a semen analysis? Do we know what that looks like from that perspective? So when I look at your history, I can get a general idea about what might be causing your ability to, or your inability to get pregnant. And it helps me determine what other tests might be beneficial for you to make that diagnosis. So if we break down all causes of infertility, as you can see here on the chart, about 15% is due to ovulatory dysfunction. So you're not regularly ovulating. About 35% is due to tubal and pelvic pathology. So the tubes not being open or scar tissue in the pelvis. About 5% is other problems that are less common, like fibroids or different shapes of the uterus. Male infertility accounts for about 1/3 of overall infertility, and then about 10 to 15% of patients will fall into unexplained category. So if we're looking at ovulatory dysfunction, it's important for me to find out if you're ovulating regularly. Now, most women should have a period cycle that lasts 24 to 35 days. So that's 24 to 35 days from the first day of bleeding to the next first day of bleeding. And sometimes that's hard to determine, but I really like it when my patients use those trackers on their phones so that they can tell me exactly how long their cycles are, because it takes all the guesswork out of it. You just plug it in and then you read it off. If your cycles are longer than that normal 20 or 24 to 35 days, then I'm concerned that you're probably not ovulating as regularly, and I need to look deeper into that. The most common causes of not ovulating regularly is the brain not talking to the ovaries very well, along with PCOS. The ovaries not having very many eggs left in them, so diminished ovarian reserve or premature ovarian insufficiency, and then elevation of your thyroid hormone or your prolactin levels. Once we talk about how your periods are going, then I ask, have you been able to detect ovulation? And so most of the time women try that testing for ovulation with just over-the-counter ovulation predictor kits. It's probably the easiest and simplest method to detect for that. And then looking at kind of other causes that might cause irregular periods or make it so that you don't ovulate. Are you having any abnormal breast discharge? This kind of puts it in my head. Do you have elevated prolactin levels, which can throw off ovulation? If we're looking for concerns for tubal or pelvic pathology, I always ask, do you have painful periods or pain with intercourse? Because if you do, you might have endometriosis. Have you had any abdominal surgery or infections that can cause scar tissue, which make it hard for you to get pregnant? Because scar tissue can block those ends of the tubes. And if the tubes are blocked, that egg's not going to make it into your uterus successfully. Other problems. So I'm looking here and trying to find out if you have very heavy periods, like you might have fibroids or polyps or abnormal growth of the lining of your uterus. I'm looking for how long you're bleeding for, again, for those same reasons. And I'm looking to see if you have a history of recurrent pregnancy loss. This makes me think of a whole slew of other things that you might benefit from testing. So like the shape of your uterus, and for any autoimmune causes of recurrent pregnancy loss, as well as genetically related causes. And then for male infertility, I ask about your partner. I ask if they've had children before. I ask if they have any history of infections or surgery that might have damaged the genital tract. Any problems with intercourse. If men have low testosterone levels, a lot of time they have issues with intercourse and are not producing viable sperm regularly. I ask if they have any medical problems or any medications that they're taking, because some medications can definitely affect their ability to produce viable sperm. Things such as testosterone or radiation or history of chemotherapy can definitely affect sperm production. And then if you're in a same-sex relationship, do you have a sperm donor that you know or would want to use? And just talking about different genetic testing options that are available if you choose to use a donor sperm. And then one of the most frustrating diagnoses is unexplained infertility. So if we don't find anything in those first few categories, then couples would fall into the unexplained infertility. And so these couples have no identifiable factor that may be making it difficult to get pregnant. And then we talk about a little bit about how the menstrual cycle works. And so I really am a visual learner, so my patients have to suffer through my drawing upside down. But we talk about how the brain talks to the reproductive system. So if you look at the diagram, the brain every month at the beginning of your period sends down a signal called FSH, or follicle stimulating hormone. And this FSH acts directly on the ovaries. And on the ovaries, you have little resting follicles, which are the fluid-filled sacs in the ovary that contain the egg. So for each follicle, there will be one egg. And so oftentimes I use these terms interchangeably. So I just don't want you to get confused. But in response to that FSH, one of those small follicles will start to grow. And when that follicle and that egg grow, they produce estrogen. And estrogen feeds back up to the brain to tell the brain, hey, I've made my egg for this month. Let's go ahead and stop making eggs grow. Let's go ahead and ovulate this egg. So when that estrogen is high enough for a long enough time, the brain gets that signal, I've made my egg. Let's switch production of FSH, making follicles grow, to a hormone called LH, or luteinizing hormone, which surges and allows you to ovulate. Now that surge of the LH is what you're able to detect on those ovulation predictor kits. And when you surge on that LH, you're going to ovulate somewhere between 24 and 36 hours later. When you ovulate, that egg is picked up by the fallopian tube, and it likes to get fertilized out there in the fallopian tube. Then about 3 days later, that egg has been fertilized and travels down into your uterus. And about 5 days after ovulation, it tries to implant on the uterine wall. And I think understanding kind of this cycle of feedback is helpful in understanding what tests I order and why, and then also how my medications are going to work to help you in this cycle. So as far as evaluation goes, based on those conversations that we had about you, about your history, about your period, I'm going to determine what labs you and your partner will need. So typically I do ovarian reserve testing, just testing those hormones that we just talked about, the FSH and LH from the brain and the estrogen level from the ovaries. I also usually get an AMH, or your anti-Mullerian hormone, which lets me know how many eggs you have left in your ovaries relative to somebody your own age. I also offer testing of the uterus and the fallopian tubes by doing a pelvic ultrasound, and then doing testing to make sure that your tubes are open through something called an HSG, or a hysterosalpingogram. And then other testing as indicated by your history. Should I test your thyroid? Should I test your androgen levels? And this is all based on what you just tell me. Usually these tests are done with the first day, or you call me on the first day of your next cycle, and then we get these labs about 3 to 5 days after you've started your period. It's the best time to test for the ovarian function, because at these points I expect your FSH and your LH to be low and your estradiol also to be low, because your body hasn't started making an egg for that month. And then the male partner, I always get a semen analysis. I hate to miss something that's right in front of me. And about 30% of couples will have both male and female factor. And then other testing as indicated by his history as well. Does he need the same hormone labs drawn? Based on his history, we'll decide. And then we can talk about some options moving forward. So I always go over the options at that new patient visit, but we're not necessarily starting anything. We're not committing to anything yet. I like to get that full picture of what's going on so that I can give you the best information about what's going to be best for you and your spouse. And so kind of our big options for fertility treatments are ovulation induction and IVF. So with ovulation induction, I use medications called Clomid or Letrozole. And what those do is they block that estrogen signal from the ovary going back to the brain. So the brain doesn't get the signal that you've made your egg for that month. So in response, the brain's going to increase the amount of FSH that it's producing. So instead of making 1 egg per month, I hope to make you make 2 to 3. Okay, that's going to increase your chance of success by increasing the number of eggs that you're ovulating. With 2 to 3 eggs, you have about a 10% risk of twins and about a 1% risk of triplets. So I'm okay with that risk as long as you're okay with that risk. Now, if you're developing 4, 5, 6, I would probably say, hey, let's take a break this month because quintuplets are not good for you. They're not good for the babies, but it's kind of a trial and error that first month with those medications to get you to that sweet spot of 2 to 3 eggs. And I monitor this with an ultrasound after you've taken the medication to see how you're responding. And then based on your response and on your husband's semen analysis, we can either talk about doing timed intercourse or inseminations. Now with timed intercourse, millions of sperm are deposited in the vagina and they get weeded out in the cervix. So if you put millions at the top of the vagina, maybe a couple thousand make it to the top of the uterus, then maybe 10 to 100 make it out to the fallopian tubes. Even with a normal semen analysis, I usually recommend doing an insemination because studies have proven it to be more effective than just medication and timed intercourse alone. And that's because with an insemination, we wash and concentrate the sperm so that I can put millions of sperm at the top of the uterus, bypassing that weeding out stage in the cervix. So millions at the top of the uterus become thousands out in the fallopian tubes, thereby increasing your chance of success. Now, if we're looking at success rates, all of the couples of reproductive age in the world have about a 20% pregnancy rate per month. With medication alone and timed intercourse, your chances of success are about 10 to 15% per month. With medication plus an insemination, you're closer to 10 to 15% per month, which is closer to that normal fertility rate. IVF is not something I usually jump to as first line treatments. I usually like couples to try ovulation induction and inseminations for 2 to 3 cycles prior to progressing to IVF, unless there's some identifiable cause that warrants going directly to IVF. With IVF, it's much more involved. It involves injectable medications that are just that hormone from the brain, FSH and LH. We bypass messing with the estrogen and directly stimulate the ovaries by giving you these injectable medications. Usually it takes about 10 to 14 days of injection medications prior to seeing that development of the follicles to a stage where we can do the egg retrieval. With the egg retrieval, it's done under IV sedation here in our office, and we go in and aspirate or suck out the fluid from the follicles and hopefully get the egg with it. The day of the egg retrieval, you know how many eggs you got. And then we have options for fertilizing the eggs, either standard insemination, or we take a single egg and put it in a petri dish and surround it with about 15,000 sperm and kind of let nature take its course. Or if there's any concern for the ability of the sperm to fertilize the egg, we can do a procedure called ICSI, where we take a single normal looking sperm and inject it into a single egg. Then we watch that egg grow in the lab for about 5 days. And so what it does is the male and female DNA bind together, and then the cells start dividing. So it divides and it divides and it divides and goes from being one cell to being 200 to 300 cells at about 5 days. And the cells have separated into two distinct groups. The cells on kind of the outside of the circle become the placenta. And then the chunk of cells that are grouped together kind of in the other corner become the baby. And so if we wanted to do any testing on that embryo, we could do it at that day 5 stage by taking a small biopsy from those cells that will become the placenta, well away from the cells that will become the baby. Now that embryo testing takes about 5 days to come back. So about 2 weeks after that egg retrieval, we'll know which embryos are normal genetically, if that's the option that you chose to do. Normally, I recommend testing genetics of the embryo for my women over 38 because I show improved live birth rates, especially in that group of women. And then when it comes to the embryo transfer, it's very similar to an insemination where we choose a single embryo and then delicately put it back up to the top of the uterus under ultrasound guidance. And that's it, my friends.
We had a question come through. What about recurrent miscarriage and pregnancy loss?
Yeah, and so that's a good question. And unfortunately, recurrent miscarriage happens more often than we like to see it. And so testing to make sure that couples with recurrent loss have a normal shaped uterus, that there's not any septums or large fibroids that could be causing the loss and easily corrected with surgery, making sure that they don't have any autoimmune disorders that might be causing the loss, such as antiphospholipid syndrome, and making sure their thyroid hormone is normal and their prolactin levels are normal. And then also potentially testing the chromosomes of mom and dad to make sure that they don't have some small change on their DNA that's being passed along and predisposing them to losses.
Excellent. Thank you for that. I do not see any more questions. However, they can always reach out to Everlasting Hope after, and we will give them to you and have them answered. Yeah. But most importantly, like again, I need to shout out your clinic, your Sanford crew from management to nurses are wonderful, let alone a huge asset to Everlasting Hope. So thank you to all of them. And we will have you back. We are excited to host you guys and do more of these educational settings beyond Infertility Awareness Week. So thank you, Dr. Rippentrop, for joining us today.
No, my pleasure. Thank you for having me.